No disclosures, but what I wanted to do is spend the next couple minutes talking to you about the most important thing that none of you guys are checking in triage, and hopefully win you over on my belief that end tidal is indeed actually a vital sign. I'm going to start with a couple of examples. This is an example of an EKG that was brought up to me by a resident in our ER. We had a real busy ED. We had no beds, and this was a gentleman in triage, middle-aged guy, who was feeling generally not well, a little short of breath. They found him to be tachycardic, and he was in AFib with RVR, basically a flutter with a rate of 150. And the resident said, blood pressure's good, he's awake and alert, we're going to move him to trauma bay because we don't have any beds, and get ready to give him some cardism, slow his rate down, get some blood work it up. Seemed like a pretty good plan to me. So I went and saw the patient. This is a picture of his monitor, and you can see, indeed, he is going pretty fast right there, and his blood pressure's good, and his saturation's good. But look at his end tidal. He is sustaining an end tidal CO2 of less than 10. In order to do that, you have to be profoundly acidotic or basically not perfusing, like cardiac arrest, not perfusing. So with one question, we actually changed our management very dramatically, which is, do you have diabetes? Yeah, actually I do. So it turned out his pH was 6.8, and instead of ending up on a cardism drip, he ended up on an insulin drip, and God knows what cardism might have done to him had we bolused him before we found that out. This is another example. This is a 76-year-old gentleman who came in with some vague abdominal complaints. He was afebrile. You can see his pressure's not so bad. His heart rate 62. He was on a beta blocker. A little bit of a low sat. Again, sustained end tidal right around 10. It turned out his lactate was 7. He had dead gut. Within about 45 minutes, his pressure tanked, and he was on vasopressors and intubated and ended up going to the OR and then to the ICU. So these sort of things got me thinking basically about what we call vital signs, what really are vital signs when we think about it, right? They're signs of life, obviously, a vital sign. They're essential body functions, and they're objective evidence of life, right? So we think about temperature and pulse and respiratory rate, the new kid on the block, oxygen saturation, right? We all pretty much accept that now. And what their functions are is that we look at them and we look at abnormalities and they mean something, right? An abnormal vital sign means to us that there is some sort of dysfunction going on and it leads us in a certain direction. And we take most of these for granted. You'd be surprised how little evidence there is on vital signs if you go into the literature. So why do I think end tidal is a vital sign? Well, it is absolutely objective evidence of life, even in cardiac arrest. What do we look for now for ROSC? We look at the end tidal jumping up before we even feel for a pulse, okay? And ventilation and perfusion are essential bodily functions. If you're hypoventilating, you're going to have elevated end tidal CO2. If you're hyperventilating, it's going to go down. Poor perfusion and acidosis decrease end tidal CO2. So they're essentially giving us bodily functions and this dysfunction. So in the most basic sense of it, you're monitoring ventilation, and it's good to know that someone is breathing, right? Whether they're breathing fast or slow sometimes matters. When we look at procedural sedation or anytime we have somebody who's obtunded, we know now from evidence that we can look at waveform capnography and know many minutes before they become hypoxic that someone has stopped breathing and it isn't ventilating right. And that's why it should be, if it's not in your hospital standard of care, to monitor end tidal when you're doing procedural sedation. Where it gets even more interesting, at least for me, is this aspect. When you get to the fact that end tidal is going to change based on your metabolism, particularly metabolic acidosis when you're blowing off CO2 and using bicarb as a buffer. Also, you have to perfuse the alveoli, the lung tissues, to get a good end tidal CO2. Cardiac arrest is our best example of this, right? We see it drop precipitously when you lose your pulse. We see it raise precipitously once you get your pulses back. That's because your lungs are now being perfused and they're able to do the gas exchange. So what do we screen for in triage? What really matters? Obviously, we're looking for sick patients, right? I mean, it's very straightforward. So why wouldn't we want to find out who in triage or who is coming via EMS that has poor perfusion, who is severely acidotic, or who is in respiratory failure? It makes sense to me that I'd want to know all those things. And we have the ability to do this in real time with a non-invasive measure, and that's using capnography and end tidal. So we're going to dive a little bit into the evidence here in this short talk. We already mentioned diabetic ketoacidosis. What I mentioned of that case report, this is true and a real and been shown, published now multiple times, both in adults and in pediatrics. DKA, you can see this very dramatic, beautiful correlation where low end tidal CO2 correlates with decreased serum bicarbonate. And you can actually, based on their sugars, draw cutoff lines. So if someone has a sugar, particularly in pediatrics, but a little bit dirtier in adults, but if someone has an elevated sugar and an end tidal of less than 25, you can almost be certain that they're going to be acidotic and be in DKA. So here's your ability to screen without getting any blood work or anything else over these patients. It also allows you to hopefully capture those kids that come in with flu-like illness but actually turn out to be profoundly acidotic and in DKA, like those first-time DKers. I also work in a pediatric ER. This is one of those age-old questions, right? Which kid needs IV hydration? They come in with gastroenteritis, vomiting, diarrhea. By the time we figure out if they actually need IV fluid, we've already stuck them with a needle and are giving them IV fluid because we got the BMP. This is a study that showed basically similarities in patients to DKA. Patients that had decreased end-tidal CO2 in the setting of gastro were more likely to be acidotic. And now you can get a guide without sticking them with a needle to know, hey, should I start oral hydration, or is this a kid? It's one more objective piece of evidence to decide, is this the kid that we stick with a line, right? So my research started in this based on sepsis. I was more interested in, I'm an EMS medical director, and I was interested in trying to find a way that we could identify severely septic patients in the field so that we could do pre-arrival notification. This is how end-tidal CO2 correlates with lactate levels. As you can see, low end-tidal correlates with elevated lactate. It's just as good at predicting mortality in septic patients as lactate. So it allowed us to create this protocol in the field where we're suspecting sepsis, use end-tidal instead of lactate, begin fluids, and call a sepsis alert. And when we used this in the field, we found that we were able to predict both sepsis and severe sepsis in over 300 patients doing it this way. Now we have criteria where we know patients are septic coming into the hospital before they get there, which allows us to reach our core measures. It does better for patient care. It also helps predict mortality and trauma. We also know lactate will do that. It also helps us determine whether or not we want to give Lasix or albuterol in a patient who's wheezing, whether we have that shark fin appearance in an elevated end-tidal or a regular appearance in a low end-tidal, which is more likely in CHF. So to end, this is the second to last slide. We actually went forward and did a prospective study looking at 1,500 patients, all comers, and found in their vital signs that end-tidal CO2 was more predictive of in-hospital mortality than any other vital sign, including blood pressure. Low end-tidal was worse for you than hypotension. So, last slide. It's a real-time objective measure. You can get immediate diagnoses. It can change therapeutic interventions, and you can monitor it in an austere environment. So as far as I'm concerned, this is a vital sign, and everybody should be checking it in Triage. And we're doing that right now at ORMC and doing a study on it prospectively, and hopefully I'll win you all over more next year. That's all I got.